Woolfield.
I'm Mele Kamen.
And I'm Carla Pecoraro, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information in all things O&G. Today, we'll cover assisted vaginal deliveries.
Now, this is a topic that brings out a lot of fear when we talk about childbirth. Some women are really nervous about the idea of needing a vacuum or a forceps to help deliver their baby, even to the point where it might be specified in a birth plan, avoid vacuum or forceps at all costs. But to understand why we might need an assisted vaginal delivery, it's important to learn a little bit about the history of instrumental births. Why did the vacuum and forceps even come into existence in the first place, Mel?
Well, obstructed labour has been around for a very long time, well before the development of various instruments used to aid vaginal birth. Previously, if a baby was stuck in the birth canal, not only would the baby die, but often so would the mother. The original instruments used to assist a vaginal birth were therefore primarily designed to save the mother in the event of an obstructed labour. In these circumstances, the baby would be stuck in the birth canal and often pass away before the doctor would get there. The original instruments used to help remove the baby were therefore not designed to get the baby out safely and were actually quite destructive. It wasn't until the early 17th century, when the Chamberlain family invented the forceps, that obstetricians realised that the baby could be delivered alive in cases of obstructed labour. The usual practice was to preserve female modesty, meaning that male accoucheurs often worked underneath a sheet. This allowed the Chamberlains to keep the forceps their secret instrument and hoard it to themselves for more than a century.
Did you know that the obstetric forceps have saved more lives in history than any other medical instrument? That's my husband's favourite fact in obstetrics.
It's such a good one.
It is.
Full of random knowledge, that boy. Now, since the Chamberlains, plenty of other obstetricians have had their own input into the design of forceps, leading to several varieties that we have available today. The vacuum follows a slightly similar trajectory, with many different obstetricians trying some form of suction traction to help delivery. Interestingly, starting with just a glass and a pump to try and help the baby get out. Didn't work, but points for trying. Now, interestingly, before the use of oxytocin, people actually used to use the vacuum to apply light continuous traction before full dilatation in cases of poor uterine activity. And this apparently had the same effect by activating the release of endogenous oxytocin through Ferguson's reflex. Interesting. And it wasn't until the 1950s when the vacuum came to be used as an alternative to forceps delivery, mainly because of less maternal trauma and the ability to perform it under local anaesthetic.
The history of childbirth is so interesting. If you want to dive further into this, there are some really good resources that we'll put up on our website. Clearly, we've come a long way with our use of forceps and vacuums, and now our goal is to benefit both the mother and the baby when we do perform an assisted vaginal birth. What are some of the reasons why we might recommend an assisted vaginal birth?
There are 4 main indications for assisted vaginal birth, including suspected fetal compromise, maternal exhaustion or distress, prolonged second stage of labour, and where there are medical indications to avoid the Valsalva manoeuvre. For example, cardiac disease with NYHA class 3 or 4, maternal cerebrovascular disease or malformations, myasthenia gravis, severe hypertension, proliferative retinopathy, or spinal cord injury at risk of autonomic dysreflexia.
Where there are indications, there are also definitely contraindications. Tell me, when is it not safe to do an instrumental birth?
Instrumental deliveries are contraindicated whenever there is a significant risk of trauma to the baby. For example, fetal bleeding disorders like alloimmune thrombocytopenia, predisposition to fracture like osteogenesis imperfecta. Vacuum specifically is contraindicated in face presentation, although you could do a forceps if the baby is mento-anterior. Gestation under 34 weeks, just note that this is the RANSCOG recommendation. The Green Top guideline actually suggests vacuums can be used above 32 weeks gestation, but that you should take caution between 32 to 36 weeks. This is because the fetal blood vessels are fragile and the pressure from the vacuum cup can significantly increase the risk of subgaleal hemorrhage in these babies.
Okay, so we're very focused on making sure we're delivering our baby safely. Let's talk about the kind of conditions that are required for a safe instrumental vaginal birth. The RANSCOG guideline very nicely divides the prerequisites into 3 categories: examination, preparation of mother, and preparation of staff.
So we start by assessing whether it is safe to perform an instrumental delivery, and this requires a full abdominal and vaginal examination. I often see juniors jump straight into a V before doing an abdo-palp. Don't be that guy. With our examination, we're looking to make sure we have all of the following. Firstly, less than 1/5 of the head should be palpable abdominally. If there's more than 2/5, you cannot proceed. The baby needs to be in vertex presentation, the cervix should be fully dilated, and the membranes need to be ruptured. We also want the station to be at the level of the spines or below. Instrumental deliveries above this station can lead to significant trauma for the baby. The exact fetal position of the fetal head should be known, and you can use ultrasound to confirm this. And look, I'm a really big fan of using an ultrasound to help determine the fetal position. Now, I usually do a VE first and get an idea of how I think the baby is positioned, and then confirm that position with a bedside scan. This also gives me some feedback on whether my VEs are right or not too. Now, obviously, there are some situations where there's just no time for a bedside scan, like in the case of a fetal bradycardia, and you just have to rely on your clinical VE skills to determine the position. So it is super important that we do maintain our clinical skills to be able to tell the fetal position on VE alone. But we are human and none of us are perfect, and I just think that if you have the time, do a quick ultrasound and confirm that position. I'm sure we've all seen births where the midwife or consultant was certain that that baby was OA, and then lo and behold, that little OP face comes out looking right up at you. Assessment of caput and moulding is also important, so you don't want any more than moderate or +2 of moulding, and the pelvis should be deemed adequate. If you have irreducible moulding, it might indicate CPD and you may be better off doing a cesarean section.
So after we've determined that it's safe to offer instrumental delivery, we need to make sure we prepare the mother. From the moment we step into the room, we should be communicating with them, keeping her and the partner informed as to what we're doing. I like to give a very clear explanation about why I think an assisted vaginal delivery is needed, what's involved in the instrumental birth, including an episiotomy, and what the alternatives are if the woman decides she doesn't want an instrumental birth. For example, she might choose to keep pushing or to have a fully dilated cesarean section. It's really important that the woman and family are informed about the risks and benefits of all options available, including what might happen if we did nothing. Where possible, written consent should be attained, but verbal consent is valid if time is of the essence.
I guess that's why it's so important that we talk about assisted vaginal birth antenatally. Like when you've been pushing for 2 or 3 hours, when you're in pain, you're exhausted, and you just want that baby out, it's really hard to have a full discussion about everything in the birth suite. Equally, if you're mid-fetal bradycardia, you don't really have time to talk about all the ins and outs of everything if you want to get that baby out safely. I highly recommend getting your patients to attend an antenatal class or to get them to talk to their obstetric physician or midwife about instrumental birth before they hit the birth suite.
Absolutely. So aside from providing an explanation and consent, we also need to make sure that we have adequate, effective analgesia on board. A regional block is ideal for a mid-cavity rotational birth, but you could also consider a pudendal block or local anesthetic for an urgent birth. The bladder should be emptied and make sure to deflate that catheter balloon or remove it completely. And we also want to use an aseptic technique, which means sterile gloves. Some practitioners also like to pour some Chlorhex over the perineum, although this isn't a standard practice.
Okay, so we've done our examination, we've prepped our mum, and now finally we need to prepare our staff. It's really important that the person doing the instrumental birth knows what they're doing, and if they're junior, that they're being supervised by someone appropriate. We need adequate facilities, so obviously a bed, good lighting, and the right equipment. Then we need a backup plan. Obviously, we're planning for our assisted vaginal birth to go smoothly, but if it doesn't, who are you going to call for help and how are you going to get that baby out? I highly recommend telling theatre if you're doing a difficult instrumental or actually doing the instrumental in theatre. And it's definitely good practice to notify your on-call consultant if you're doing an instrumental birth, mainly so that if they're needed, they're awake and they're ready to help you out. We always like to be prepared, so we also anticipate a PPH, a shoulder dystocia, and a neonatal resuscitation. So we make sure there are staff present that are able to manage those complications if they arise. For example, a paediatrician, those sweet, sweet saviors.
What a list to remember, but also very important. So let's now talk about the classification of instrumental vaginal births. We've got mid-cavity, low, and outlet. What's the difference?
So mid-cavity is where the leading point of the skull is at spines to +1. Note, we're talking about the skull, not the caput. Low is where the leading point of the skull is at 2+ or more, but not on the pelvic floor. And an outlet is typically when the fetal skull has reached the perineum, but the fetal scalp, and it's typically visible without separating the labia. We can also classify instrumentals as non-rotational or rotational. So non-rotational deliveries are when the sagittal suture is less than 45 degrees from the OA position. Rotational is when there's rotation of more than 45 degrees, and this includes OP. It's important to note that the instrumental delivery is not recommended when the head is 2/5 or more palpable abdominally and when the presenting part is above the ischial spines.
And I often hear about people doing a trial of instrumental. How do I know if something is just a normal instrumental or if it's a trial?
We tend to consider an instrumental delivery to be a trial if there is a higher risk of failure. So higher rates of failure are associated with a maternal BMI greater than 30, an estimated fetal weight of greater than 4 kilos or a clinically big baby, OP positions, mid-cavity or when 1/5 of the fetal head is palpable abdominally, short maternal stature, and where the head circumference is greater than the 95th centile. Some hospitals have a really good system called the 3-bell system. Basically, you consider 3 things. Parity, so if you're nulliparous, you get 1 bell. If you're a multi, you get 0 bells. Station, if it's 0 to +1, you get 1 bell. If it's +2 or lower, 0 bells. And position, if it's OP or OT, you get 1 bell. And if you're OA, you get 0 bells. Any instrumental with 2 or more bells should be considered to be a trial. And these instrumentals should be conducted in a place where you can quickly convert to a caesarean section if the instrumental fails. There is a high risk of fetal injuries when there's a delay between failed operative delivery and a Caesar, but if you can do a Caesar immediately, then there's little evidence of increased maternal or neonatal morbidity.
Although I've only worked at one place that uses the bell system, most facilities will have guidelines regarding trial of instrumental when it should be coming to theatre or when the consultant needs to be called in. On average, instrumental delivery undertaken on birth suite takes around 15 minutes, whereas if you do it following transfer to theatre, it can take around 30 minutes. Although this really does depend on the hospital you work in. Some facilities where you transfer to theatre, it's incredibly rapid and trial of instrumental, maybe even performed in birth suite. So if you do need recourse caesarean, it can happen quite quickly, as long as your theatre is set up that way.
And what's the deal with the episiotomy? I remember in our Oasis episode, we spoke about the recommendation for episiotomy for instrumental deliveries. Does this mean we have to do an episiotomy for every instrumental?
The recommendation from the WHA Perennial Care Bundle is that episiotomy is indicated for all women having their first vaginal birth requiring a forceps or ventouse assisted delivery. In general, it's also good practice to do an episiotomy for all forceps deliveries. Multiparous women having a vacuum delivery may be able to get away without an episiotomy.
Okay, let's actually do an assisted vaginal birth. Let's get into the final details. It's obviously a lot better to learn how to do a vacuum in person, so we won't go into extensive detail. But there are definitely some key points to remember. Firstly, where is that flexion point?
All right, so the flexion point sits 6 centimetres from the anterior fontanelle and 3 centimetres from the posterior fontanelle. It's in the midline over the sagittal suture. This is where the vacuum should be placed to allow flexion of the head with traction. If you place the cup too close to the anterior fontanelle, you may actually cause extension of the fetal head during traction, which increases your risk of a failed instrumental up to 30%. And of course, you want to make sure there's no maternal tissue underneath the vacuum cup. It's always more posterior than you think. The Aldo-Vaca technique recommends that you use your fingers to measure where the flexion point is, then using the measuring lines on the vacuum so you know exactly that it's in the right position. The risk of subgluteal hemorrhage is increased if the cup is positioned incorrectly.
The next key point is establishing negative pressure to a maximum of 500 to 600 millimeters of mercury. Some people like to do this slowly over a contraction or so in order to reduce the detachment rate, but Ranscock actually recommends that rapid negative pressure can occur as it reduces the duration of the procedure with no actual difference in maternal or neonatal outcome or detachment rate.
Then your traction should be steady, applied only with contractions and only with maternal effort. You should have one hand maintain all the fetal flexion, usually your non-dominant, and supporting the vacuum cup, while the other hand applies sustained traction to assist delivery of the fetal head without rocking or twisting movements. This direction should follow the axis of the pelvic curve. Adequate descent should be verified with your non-dominant hand, the one that's touching the baby's head, and then the traction should not be prolonged.
It's also important that we know when to stop. If the vacuum isn't working, continuing to pull is only going to cause trauma to the poor little baby. In general, vacuum should be abandoned in 1, after 3 pulls if there's no descent to the perineum, 2, after 3 pop-offs, although you should be rethinking your life choices after 2, and 3, 30 minutes of the decision to deliver.
Now, these are guidelines. If that baby isn't moving at all after 1 or 2 pulls, then I'm not going to wait for a 3rd pull to call it. Equally, if the head is coming, particularly if it's descended to the perineum, it is okay to do more than 3 pulls to help deliver the baby, keeping in mind that there is an increased risk of subgaleal hemorrhage with increasing numbers of pulls.
Up to 3 detachments would generally be considered acceptable, but reapplication of the cup on each occasion should only be considered when there's been definite progress with the preceding pulls or the head is on the perineum.
VACA recommends an upper limit of 20 minutes from first application of the cup. Where birth is not imminent after 15 minutes, operators should evaluate whether further traction is warranted and consider recourse to caesarean section. It should be noted that where the head is deeply engaged in the maternal pelvis and macrosomia is not anticipated, that completion of vaginal birth by vacuum extraction or forceps may still be a safer option than a caesarean section.
Now, we've been talking a lot about vacuum, but it's important to note that we are really referring to the OmniCup. There are actually several other types of vacuums, and while we don't typically use those anymore in Australia, it is good to know about them. So rigid cups, such as the Malmstrom vacuum extractor, were some of the first commonly used vacuums developed in the 1950s. They had a high success rate, but were associated with a fair few scalp injuries. Because of this, the soft cups were developed. While these did reduce the amount of scalp trauma, they also came with a high rate of failure, which was incredibly frustrating, up to 25% with soft cups compared to 2 to 4% with metal cups. Aldo Vaca, the infamous Brisbane obstetrician, advocated a return to the design principles of the rigid cup, but better, and is responsible for creating the plastic flat OmniCup. This happened as recently as 1999 and is now the main vacuum cup used over the world today.
So impressive.
Woohoo, Brisbane!
Go Vaca. It's also super interesting to note that there may be a new contender in the world of assisted delivery. George Odin, a car mechanic from Argentina, came up with an interesting idea after watching a technique to remove a loose cork in a wine bottle, presumably while procrastinating on TikTok.
Me too.
The Odin device is basically a plastic sleeve that is inflated around the baby's head to gently pull and ease the head out of the birth canal. Now, this device has actually been manufactured, and the World Health Organization has set up the Odin Device Research Group to study its feasibility and safety. The idea being that it might be a simple, low-cost option for low-resource settings. And we are hoping it will be quite safe and not need skilled operators. Actually, the results so far have been quite promising, and more information is coming as we await the results of the Assist 2 trial and then the planned RCT that will directly compare the Odin device with the Ventouse.
What? I'm never going to look at a loose cork in a wine bottle the same. That's so exciting.
Yeah.
Wow, what a genius. Why
It's
don't
very
we have an
clever.
invention? Anyway, stay tuned for the uterine sound invention. Okay, so I'm feeling pretty confident now with my knowledge of the OmniCup. Let's get into forceps. When might we prefer a forceps to a vacuum?
So, a few instances. 1, where there's excessive caput present over the vertex. You're not really going to get a good suction, and that's when it increases the risk of the vacuum. When there's prematurity, less than 36 weeks. A face presentation, although, I mean, that's not just a strict, you want some senior people involved if you're delivering a face vaginally. The aftercoming head of a breech. Maternal conditions that preclude pushing, so things like maternal cardiac disease, or where there's insufficient maternal effort, and suspected coagulopathy of the fetus. The forceps has a much lower failure rate than the vacuum, so you should definitely consider it where it seems like a vacuum delivery might not work.
And again, it's obviously better to learn how to do a forceps in person, but what are the key points to remember with performing a forceps?
Always wait until the contraction has stopped and then insert the left blade first. I like to use a lot of obstetric cream to help me use my right hand to guard and protect the vaginal walls. You want to hold the left forceps with the left hand in a pencil grip and keep that handle vertical. Follow the curve of the pelvis and slide that forceps in gently with the help of your right hand to ease it in. Then insert the right blade in a similar manner, again protecting the right vaginal wall, and check to make sure those blades are in position and that they lock.
You'll need to check that you've got the right application by making sure the sagittal suture is in the midline, equidistant from the blade. The posterior fontanelle is 1 finger breadth above the shanks. That's the handle bit. The fenestrated blade admits 1 fingertip between the heel of the blade and the fetal head. Apply traction with contractions. Use pressure perpendicular to the handle and downwards to maintain flexion and follow the direction of the pelvic axis.
And I was taught this mnemonic where it goes back to back, ears in the air, right over left makes a pair. So it's hard to use that without forceps in front of me, but write that down when you do see it in front of you. And then don't forget your episiotomy. It's usually done at the time of crowning. Once the posterior fontanelle is below the symphysis pubis, the handles are elevated in a J movement. Forceps are removed in reverse order once the jaw has delivered.
Now again, here we are talking about the Neville-Barnes forceps. After forceps were invented, nearly every obstetrician tried to improve upon the original design, adding cephalic curves, pelvic curves, and axis traction, which is why we have so many different forceps. Everybody wanted an instrument named after themselves. But there are a few other types of forceps that you should know about. For example, the Wrigley's, the Piper, and the Keelan's.
The Wrigley forceps are typically used at the time of caesarean section or an outlet forceps. They have shorter handles. The Piper forceps are used for delivery of the aftercoming head of the breech. We'll go into these into more detail in our breech episode. Then there's the Keelan's.
This is the unicorn forceps that only a few with very trained hands are capable of performing. Keelan designed straight forceps in 1910 with only a slight pelvic curve designed to deliver the OT or OP baby from the mid-cavity. So what should we know about the Keelan's forceps?
The Keelan's forceps are used for rotational deliveries and have a sliding lock to allow correction of asynclitisms, which is really common with these malpositions. When performed by a skilled operator, Keelan's are less likely to fail and less likely to cause neonatal trauma when compared with a rotational vacuum. When compared with caesarean section, there's an increased but small risk of traumatic intracranial hemorrhage and cervical spine injury. This needs to be balanced against the risk of a fully dilated caesarean section. There's been a reduction in the use of rotational forceps in the last 3 decades, and thus getting training in Keelan's is getting harder and harder to come by.
All right, so let's go into the complications of instrumental deliveries a little bit more. I'm going to go out on a limb and say they'll be divided into maternal and fetal complications. So let's start with the maternal ones. What are the risks to mum with an instrumental delivery?
So the main risks to mum are the risk of significant tearing and oasis. The risk of any significant tear is about 10% with a vacuum and 20% with a forceps. The risk of an oasis is only 1 to 4% with a vacuum and about 8 to 12% with a forceps. The risk of postpartum hemorrhage is also increased with any instrumental delivery, quoted as 10 to 40% by the Green Top guidelines. Uterine, cervical, bladder, or urethral injuries are possible but are actually quite rare. And damage to the pelvic floor and anal sphincter can also occur, causing urinary or bowel incontinence. Forceps are associated with a 2 times increase in the risk of fecal or flatus incontinence that persists for up to 5 years following delivery. And actually, in the history, while we used to be concerned about the safety of forceps for the baby, we now tend to be a lot more concerned about the safety of instrumental deliveries for the maternal pelvic floor. So there's been a big shift in our concern.
Fetal complications include subgaleal hemorrhage, which occurs in about 1 in 300 vacuum deliveries. The less severe swelling is called cephalohematoma, which occurs in 1 to 12% of all deliveries. Facial nerve palsy, corneal abrasion, and lacerations may occur with forceps. Skull fracture and intracranial hemorrhage are incredibly rare, thank goodness. These only occur in 1 to 600 to 800 instrumentals. Cervical spine injury occurs in 7 in 10,000 rotational forceps births. Retinal hemorrhage, somewhere between 17 to 38% in vacuum, and jaundice, somewhere between 5 to 15% in both.
There's a really nice little summary comparing the differences between forceps and vacuums that we'll put up on our Instagram summary later in the week. But in general, vacuums are more likely to fail and cause fetal complications such as cephalohematoma, retinal hemorrhage, and jaundice, but they're less likely to be associated with oasis, vaginal trauma, incontinence, or pelvic organ prolapse. Forceps are less likely to fail or cause fetal complications, but are more likely to be associated with oasis, vaginal trauma, and incontinence. There's no difference in the overall risk of neonatal injury or in APGAR scores at 5 minutes. In general, the obstetrician performing the birth should choose the instrument that is most likely to achieve the birth and least likely to cause complications based on the clinical situation in front of them.
Back in 1989, the vacuum was advocated as the instrument of first choice because of the reduction of maternal pelvic floor injuries. The downside of this approach was the increased risk of failed operative delivery and the sequential use of instruments, which has increased risks to the mother and to the baby. The use of sequential instruments, mainly vacuum followed by forceps, is associated with an increased risk of oasis and PPH for the mum, and an increased risk of neonatal trauma, including need for mechanical ventilation, seizure, facial nerve injury, decreased APGAR scores, intracranial hemorrhage, retinal hemorrhage, and feeding difficulty. When you put it like that, it might be easy to think that if a vacuum fails, then going straight for a Caesar is the safest option. But a fully dilated Caesar has risks as well, and the operator must balance the risks of caesarean section following failed vacuum with the risks of forceps following a failed vacuum. Also, a successful vaginal delivery increases the chances of subsequent successful vaginal births. And if a woman does have an instrumental delivery, she only has a 5% chance of needing another instrumental delivery in her next birth.
Oh, it's so tricky making those decisions, but that's why we love it. Because when you see more and you learn more and then you get better at it. So we'll go into the risks of a fully dilated Caesar more in our upcoming episode on Caesar. But for now, let's talk about management after an instrumental delivery. What are the key points we need to consider?
Firstly, don't forget the cord gases. In fact, I really like this part. Usually my stress levels have reduced because the baby has successfully delivered. I can see that the anal sphincter is intact, and so just chill out while I take the cord gases. Next, we want to chart some regular analgesia, typically Panadol and NSAIDs. VT prophylaxis should be considered for all postpartum women as per your local guideline, and having an instrumental does increase this risk slightly. We also want to watch out for any voiding dysfunction and make sure they see a physio to help reduce the risk of urinary incontinence. And every woman should have a debrief with their birthing team where possible, where they get the chance to discuss the reasons for the assisted vaginal birth, review what actually happened and why, and give them an opportunity to ask any questions that they might have had regarding their birth experience.
And don't forget the antibiotics. So the ANODE trial showed that administration of IV augmentin, 1,000 milligrams plus 200 milligrams, within 6 hours of instrumental delivery was associated with a reduction in maternal infection within 6 weeks of delivery, with a number needed to treat of only 13. Now, IV augmentin can be a bit difficult to get access to, so cefazolin 2 grams or 600 milligrams of clindamycin are reasonable alternatives, but these have not yet been studied in a non-inferiority trial. If the woman declines IV antibiotics or doesn't want to drip in, then you can also consider a single dose of oral augmentin duo fort, 875/125 milligrams, within 6 hours of birth.
Excellent. So I'm sure the question a lot of people have on their minds is how common are assisted vaginal births?
So the latest stats we have from the Australian Institute of Health and Welfare report in 2021. So 12.1% of women had an assisted vaginal delivery, 7.2% was vacuum, and 4.9% forceps. Instrumental births decreased with increasing parity and were more common in women who'd not previously given birth. So that's 12% with a vacuum and 9.5% with a forceps, compared to those who've got a parity of 4 or more, where it was 0.5% for a forceps and 1.8% for vacuum.
And with that comes our next question. How can we reduce the rates of instrumental deliveries?
There are some non-operative interventions to reduce the need for instrumental birth, as laid out neatly in the Ranscott guideline. Simple things like continuous support during labour can reduce the risk of instrumental. Birth position in the second stage of labour is also important. The upright or lateral position if no epidural, and the lying down or lateral position if using an epidural. It was previously thought that epidural itself was associated with an increased incidence of instrumental birth. However, the Ranscott guideline has suggested that some of these differences may be associated with a complicated labour rather than with the epidural itself. Moreover, studies reporting an increased risk of operative delivery with epidural tend to have been older studies, and this effect has actually not been seen in studies since 2005, since we've started to use lower dose epidural techniques or patient-controlled epidurals.
Other non-operative interventions include delayed pushing for 1 to 2 hours in nulliparous women with an epidural with a relative risk of 0.59, or until they've got a strong urge to push. This can reduce the need for rotational or mid-cavity deliveries. A recent meta-analysis concluded that when the analysis is restricted to high-quality studies, that the effect is smaller and doesn't quite reach the statistical significance. Oxytocin. So there's insufficient evidence to recommend routine oxytocin augmentation for epidural analgesia as a strategy to reduce the risk of instrumental. The use in nulliparous women with an epidural in second stage reduces the need for a non-rotational forceps. This evidence comes just from one study, and NICE does not recommend routine center for nullips based on this one study. But caution in our multiparous women. We need to exclude abnormal presentation, cephalopelvic disproportion, uterine rupture, and depends where you work, but certainly where I've worked before, any oxytocin in multiparous women needs to be discussed with a consultant. Next one is manual rotation. So to turn the fetal head to an occiput anterior position reduces the need for Caesar and increases the rate of spontaneous vaginal delivery. There's insufficient evidence to recommend routine prophylactic manual rotation in the second stage of labour. However, success rates of up to 89% have been reported. It's lower when performed in nulliparous women before full dilatation or where there was evidence of obstruction before the manual rotation was attempted. When successful, there's a significant reduction in caesarean rate with an increase in spontaneous vaginal birth and instrumental rates.
Far out. I'm feeling way more ready and definitely more prepared. Does anyone have any last tips?
I'd say when you're learning, I'd recommend practicing all these steps on your head with every assessment. So I do the same assessment at every vaginal exam and birth suite. And I also watch how other colleagues talk women through instrumental vaginal delivery. This is a skill.
Thanks, Anne. That's such a good point too. Communication. Thanks for listening to The Uterine Sound. Check us out on Instagram at The Uterine Sound or via email, theuterinesound@gmail.com, or on our website, theuterinesound.com. Let us know if you have any questions, queries, or want to fact check us.